Cardiac imaging is quite critical in the whole management process. Firstly, identifying the right patient for the procedure, and in terms of transthoracic echo, identifying severe aortic stenosis, and in terms of in Tavi planning, CT is quite critical now in terms of measuring the aorta, which I'll take you through in the next few slides. So the main thing with Tavi is that we want to minimize paravalvular leak after implantation, because the original native valve is not removed. It's basically pushed to the side. The two main causes for paravalvular leak include undersizing of the catheter valve in relation to the aortic annular size or incorrect device positioning. In terms of annular sizing, the annulus is not a circular structure. It's more three-pronged coronet rather than a circle, and it has three anchor points at the nadir of the aortic cusp. And any single diameter cannot adequately measure the annular size, and that's why a 3D measurement is much more accurate in getting the overall picture. So from CT, because it's a volume detector, it provides reproducible measurements of the annulus. It allows to measure your maximum diameter, minimal diameter, the circumference, and also the overall root geometry. And it can produce reproducible and robust sizing recommendations. So the important thing from the CT is that you be able to line up the cusps and get the basal ring and provide accurate measurements of the basal ring. It also allows to assess the distribution of the aortic valve calcification and aortic root calculation. The incorrect plans, as you see on the picture here, is measured too low, and that will provide inaccurate data for correct sizing of the aortic valve. Or if the plans are not orthogonal to each other, you have a wrong measurement as well. So it's important to get all those right. So in this case, you can see that you have the three orthogonal planes that allows you to measure the annulus accurately, and you can also see the calcification in the aortic root there, which, as you can see here, extends down along the anterior mitral leaflet, and that's quite a sizable chunk of calcification, which can potentially cause problems during valve deployment, as it's much harder to push large chunk of calcium aside, and that's a potential risk for paravalvular leak. And along with assessment of the root, that also allows us to assess the coronary osteal height, and that allows the implanter to work out with the size of the device whether it'll be safe enough or having enough clear margin to allow implantation of the device without blocking up the coronary arteries. The other thing that's critical from the CT is measuring the coaxial angle, and this is basically predicting the angle that's required in cath lab during deployment ahead of time. And once the image is acquired, you have plenty of time to sit at the computer and work this angle out, rather than when you're in the cath lab requiring repeated aortic root injections with contrast. As often these elderly patients, they have renal impairments. You want to minimize the procedural time, you want to minimize the contrast usage time, and which is the angle that you want to predict or get as close to as you can during implantation, so that there's minimal further imaging required during implantation. The other thing that's important to assess with CT is the peripheral vasculature. As often a lot of these cases are done through the transfemoral route, it's important to work out the size of the peripheral vessels, tortuosity, burden, and pattern of the calcification, particularly in terms of circumferential horseshoe calcification, as the vessel has a lot less to give in those circumstances, the extent of atherosclerosis, and all the high-risk features where the patient's got aneurysms or dissections. So in this picture here, the vessels are tortuous, but there's no calcification. Whereas the more common cases, there's a lot more calcification that we see in the typical 80, 90-year-old patient that I'll deal with. Here, there's a high-risk feature, identifying a localized dissection in the artery there. And when you have the wrong sizing, you want from the CT, you want to get the right sizing and prevent vascular complication. But Tavi is not for everybody. This is a patient we scanned yesterday with mechanical aortic valve and associated endocarditis with paravalvular, with anterior valve dehiscence. He's going for surgery today. And that's all the vegetation attached to the valve. I'll leave that to Carl now.